All right, well, welcome back to the IndeVets Happy Hour. I am your host, Dr. Andrew Heller, DVM. Unfortunately, we do not have Marissa Brunetti, VMD, here with us today. She is on vacation. Where'd she go? She went to Greece, right?
Greece,
yes.
yeah.
And through the grapevine and through Instagram, I think we all found out some very, very fun and exciting news about Marissa, that she is now engaged. Woo!
Yay!
To an amazing guy. Yeah. Congratulations, Marissa. We're very excited for you and for Hakeem, who's an awesome dude. I actually think I've known him longer than you have, Marissa, so yay me. But no, he's a great guy. Good job snagging him. And congratulations, Hakeem, too. You got a great person there. All right, so today we're taking a little bit of a break from the Ophtho series. I didn't want this to get too stale because my guests that I have on today and I and a bunch of other people I know were at the AVMA Convention here in Philadelphia, which was amazing to have in our backyard. And we learned a lot. And I'd say a couple of things about the AVMA. It was the best AVMA I've been to. I don't know about you guys. I want to introduce you guys in a second. But did you guys enjoy it? Did you guys think it was worthwhile?
Yeah.
I liked it. It was the only one I've ever been to, so I don't have anything to compare it to, but I thought it was pretty good.
Same here.
Yeah, and you know, with the pandemic screwing things up over the last few years, maybe I'm just excited that it just seemed very almost normal to me. So it was great. So anyway, first up, I want to introduce the guests. We have Dr. Chaundra Schofield, VMD, and she is the area medical director at IndeVets down in Maryland and Virginia.
Hi.
All right, and we've got Dr. Kelly Dunham, DVM, fellow Rossi. She is the area medical director in New Jersey and New York. So hello, Kelly. Welcome back.
Hello.
She's waving. And last but not least, we've got Dr. Amy Lloyd, VMD?
Yes.
Yes, I was right on that one. Damn. Well, we're about even now. 2 DVMs and two VMDs. Amy Lloyd is our AMD here in the Pennsylvania state, the great state of Pennsylvania. And she doesn't live too far from me. So welcome everybody back to the show. I know you guys have been on here before. Always great to have your feedback. All right, so today, as I said, we are going to go through what we learned at the AVMA convention. And I know you three were there, and we actually went to some of the same lectures, so we're going to have a nice little conversation. I'm not going to summarize everything I went to. I did probably, about 15 hours worth? I don't know about you guys.
22.
You did 22? Wow, you guys did better than me. It was great, and actually I was really like a sponge when I was there. I hadn't done a lot of CE in the last couple of years, and so it was really nice to see some new things. So I took a lot of notes, and hopefully you guys did too, and we can talk about some things we learned. So first up on the list, it was actually in order of what I saw. So I actually went to some emergency lectures from Justine Lee. She's the vet girl, for those of you who don't know her. She's awesome. And she was there lecturing on ER medicine. Specifically, what I saw was treating certain toxicoses. And there are some things that I just wanted to say. You guys have this in front of you too. So tell me if you guys knew this. I mean, I don't think I've ever given hydrogen peroxide to cats, and I don't think I ever would. But I don't know if I ever heard that it's toxic to cats and causes a hemorrhagic gastroenteritis and usually death. And really that there's no safe at-home remedy in cats. For dogs, there's so many different things that we can do. So you guys probably knew that. I just didn't know that because I don't see a lot of cats that ingest poisons. So
I mean, cats are easy. You just give them an oriental rug and they'll vomit.
Perfect. Well, so I have here written down what we would use in cats if we want to get them to vomit. So what are the two things that you guys would use to induce emesis in a cat?
Hydro is usually my go-to.
Okay, great.
I've used Dex before.
You use dexdomitor?
Yeah.
She said Xylazine is not as good as dexdomitor or hydromorphone, and dexdomitor works about 81% of the time, hydromorphone about 75% of the time, according to the studies. 7 mics per kg IM with dexdomitor usually does the trick. There are some other things that she mentioned, things that I didn't know how to use before. One drug was cholestyramine, and it's a great drug to use when trying to detox a patient who ingested a drug or poison that undergoes enterohepatic recirculation, since it's a bile acid sequestrant. So the name of that again is cholestyramine. Did you guys know that one?
Nope.
Good, then I'm glad I wrote it down. There were another couple things that I learned. One was something I never learned about in vet school at all, which was intravenous lipid emulsion. Did you guys know about this? It's probably just an ER trick, but basically it's IV fat, and it helps draw out fat-soluble toxicants. Usually it's made from soybean oil. It's really great for treating marijuana toxicosis because marijuana is fat-soluble among many other drugs, but it's super cheap, she says, and I'm sure you guys can look up how to use it, but super cheap, it's IV, and usually within like half an hour, you notice major differences in the way the animal is acting. Just sucks out the toxins from the tissues, which is really cool. Now, lastly, this is sort of just a refresher for me, but do you remember what the shock organs are for a dog and a cat? Bueller? So for a dog, it's their gut, and for a cat, it's their lungs. All right, so we can move on to the next one. Dr. Fox Alvarez from the University of Florida lectured on lymphoma diagnostics, and there was a lot of really good information here. She talked about differentiating different types of lymphomas with flow cytometry, immunohistochemistry, immunocytochemistry, and PCR. It was a great refresher. But one thing this is more of like a quiz question. Are dogs more commonly diagnosed with large cell or small cell lymphoma? Did you guys know the answer?
Large cell.
Large cell. 70 to 95% of the time, it's going to be large cell. And for cats, it's 50-50. So just a good rule of thumb to know when you see lymphoma. Anything to add there? Did either of you go to that one?
I didn't go to that one, but I was going to say I just saw a patient yesterday who had metastatic large cell lymphoma.
Sad.
So very sad. He was being managed all right on Pred for now, so hopefully, fingers crossed, it keeps up.
Fingers crossed. Did anybody attend Vivian Gomes' pregnancy toxemia lecture?
No.
All right, so this was good because I don't do a lot of repro medicine. I live in a city where most people are not breeders, and we don't see a lot of this in the cities. So I was really focused on learning a little bit more about neonates and pregnant animals. So what I learned about pregnancy toxemia is actually that term gets thrown around a lot in a lot of different species, and it means something different in every species. So in dogs, it's really referring to hypoglycemia. And there is also a secondary one, which is hypocalcemia, but that's usually exacerbating the hypoglycemia. And what predisposes dogs to this pregnancy toxemia is a large litter size, and also anorexia and stress. So knowing that, you can tell the risk factors and the predispositions there. So really, just to treat pregnancy toxemia, it makes sense. Dextrose IV. Make sure to feed calorie-dense foods from about 7 weeks gestation and beyond into peak lactation. Now, I know, Kelly, you wrote something recently for our doctors about this, and I sent you this info because I was like, it was on my mind after the AVMA. Pregnant animals will need, pregnant and lactating bitches will need up to 300% of normal calories during peak lactation.
I was going to say, I think most commonly, I typically recommend feeding a puppy food during that period as well. Usually I typically recommend the Royal Canin puppy or kitten if we have a kitty cat.
In the first hospital I was at, we saw a lot of breeders. We actually had a breeder discount because we were in a semi-rural area, and we saw good breeders. And I did see a couple cases of pregnancy toxemia, and it is very scary. The dogs do come in completely flat out, and we had actually an in-house calcium as well as glucose, even though we had a very small lab, and we did usually replace calcium as well as glucose and educate the owners. And we did see it with large litters, just like they're saying. And most of our breeders in that hospital were very aware of it and very aware of preventing it.
Yeah, I think one of the cases she showed in the lecture was like a 15 pup litter. It was crazy. So definitely those big litters. All right, so the next one is this was one that I thought sort of blew my mind. This was a topic about treating hyperlipidemia, and Chaundra, I believe this was your housemate in vet school who taught this lecture. Her name was Eva Furrow.
Yep.
And I think she's out in Minnesota now, right?
Yep.
Yeah. Anyway, so just to refresh everybody, mini schnauzers are the poster child for hypertriglyceridemia. And Shelties are actually the poster child for hypercholesterolemia. So those two breeds always have this on your differential list. Pretty cool, though. So the one thing I got out of it, which I didn't know before, was, how many of you guys just treat hyperlipidemia with a diet change? That's probably the most important thing is that low-fat diet. But what she taught me, and you guys might know this, but only 25% of cases are resolved from diet change alone. And if you add in this one drug, which I'll give the big reveal in a second, if you add in this one drug, 80 to 100% of cases should resolve within a month. So the name of that drug is fenofibrate. And treatment is 4 to 10 mg per kg twice a day. Typically, she recommends using the micronized form. I can't remember why, but she said, look for the micronized form. It's better. So that was a really great lecture. I came out of that saying, wow, I definitely learned something. I think it was one of the first lectures I saw. So, all right. So derm updates. So this was a lecture that was sort of an update from the dermatology conference. So this dermatologist came and told us, went through all the new updates and all the new studies and kind of just did like a quick breakdown. So there were only a few things that I thought were particularly interesting. One was there's this product called chlorpactin, which is basically a powdered chlorine. And if you use this powdered chlorine, 0.4% topically, it can actually kill methicillin-resistant staph within 10 seconds. So a lot of dermatologists are using this stuff. I don't know how expensive it is, but chlorpactin, it's basically chlorine. Bleach is also something that people, I think bleach and chlorine are probably similar in composition, but I think diluted bleach was something that works well too. So if you guys do see methicillin-resistant staph out there, topical is going to really be helpful, and chlorpactin is one of the things. Another thing that I thought was really interesting, she talked about Demodex gatoi, and there was a study done that 90% of cats were shown to have it, even if they don't find it on skin scrapes. And most of the time you can't find it on skin scrapes. I think they were doing either PCR testing or some other testing to see if the cats had it. But up to 90% of cats in the general population have this. So certainly it's out there more often than people think.
It's always hard with skin scrape too. Anytime I'm scraping for a client, I always tell them, if I see it, it's there. If I don't see it, it could still be there.
Right. It's nice when you do see it, because then you have a definitive. But
yes.
Yeah, when you don't see it, it's like, I still can't rule it out. The last thing I learned in this was that how many of you guys use Cytopoint and Apoquel together?
All the time.
Pretty often.
Anyway, there was a study done that said when you use the two in combination, meaning one or the other is not working effectively on your patient, when you do them in combination, 61% of the time, it'll actually help when using both together, when one of them didn't work alone. So I thought that was pretty interesting. So definitely going to make sure I think about that more often.
Yeah, I love it. They're my two favorite drugs.
Yeah, I mean, made by the same company, they're doing pretty well.
Yes, I should have bought stuff.
How much longer until it's generic, huh?
One day.
Yeah, one day. All right, I think some of you guys were in the pediatric emergencies lecture with me, right? I thought, no?
No.
Okay. Well, Penn's very own Vince Thawley, he's in the ER department. Well, the VMDs here might know him, at least Chaundra.
Yeah, he was doing his residency while I was there.
He was in your resident, yeah. Okay, cool. Yeah, he was great. Great lecturer. He talked about the 4 H's that we see in the pediatric emergencies. And I was asking Marissa this afterwards. I asked her if she knew the 4 H's. She got 3 out of the 4. The tough one was hypoxemia. But the other 3 are hypovolemia, hypoglycemia, and hypothermia. And so when you see a pediatric come in, it's almost just assumed that they have one or all of these 4 H's, and just to treat them for all of them. Because the issue with testing on these little guys is that they have so little blood volume, and it's really difficult to get definitive diagnoses. So if you just treat the 4 H's, you're pretty much going to get them back to normal unless it's some congenital issue. But did you guys also know that hypothermia in pediatrics is different than hypothermia in adults? So what I did learn was that the normal temp for a dog in their first week is 94 to 97, which I thought was interesting, and I don't know if I would have known that. But so if you see one and they're in that temperature, don't think that they need heat support. They might need heat support, but if they'd probably be lower than that. Their body temperature would be lower than that. It's not until the second week that they go up to 98 to 100. So really be careful about giving them heat support because you really don't want to overheat them.
Good to know.
Yeah. Next topic, urinary tract infections by Dr. Granick. Was anybody at this one?
No.
Geez, you know what? This just shows there's so many different lectures. You know, there were so many to choose from that we didn't even go to the same ones. Were you guys in a lot of the same ones together?
We were in a few together.
Wow. Yeah. Well, again, it was a great conference. A lot of variety for everybody.
Lots of options.
Lots of options. It was great. And I just want to say, people out there, if you haven't gone to the in-person conferences, I highly recommend it. They're just so much different from doing the online stuff. And now I remember why we went to them. You get to see all your friends from vet school. You get to go out at night and usually expense it to your company. So, you know, it is a nice little vacation. You still get paid for it and you get to learn. And we're all a bunch of nerds, right? So we do want to learn. All right. So some things I learned about UTIs. I always thought that if you were going to culture, you really needed to do a cysto. But this doctor said, no, a midstream free catch is fine. I always thought it was actually like just, if you think about, you know, common sense, like it should have flushed out the bacteria from that, you know, from the initial, but I never felt comfortable doing it. So now I think I would feel comfortable. How about you guys?
So what's funny about that is that I had trouble characteristically with this one dog that I kept trying to get a culture on, get a cysto on, and the dog kept peeing before he came in. And I talked to a microbiologist at Penn, and she said it was okay. So I consequently sent cultures to her if I did them that way. But if you then send that pet to a specialist, then they will tell the owner that you are wrong. At least that's been my experience.
Wait, so they'll tell the owner that it needed to be a cysto?
Yes, I've had that happen to me.
Yeah, well, Dr. Granick's a specialist, so I'm going with what she says.
Yeah, you just have to be careful because there's a well-known local specialist who is wonderful, who if you tell him that, he will say, no, 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 no.
Yeah. Well, you can't teach an old dog new tricks, I guess. So the next thing that I learned, which I actually think I already knew, and we did a podcast on this last year when we did UTIs. I used to treat UTIs, like just, you know, sporadic UTIs for 2 weeks. But the new recommendation is 3 to 5 days for sporadic infections. So I already had been changing over to that. It's still hard for me to do just because it was so ingrained in me to really do a full 2 week course. How about you guys? Are you down to the 3 to 5 days too?
I'm trying.
Yeah.
You're trying to get there.
It's hard.
It's hard as relief too, because if that's not what the hospital is used to, they're going to question it more and maybe doubt you. So I think it's harder for us to make that change than if we were in a hospital all the time.
Yeah, and I have to admit, I remember when I was still stuck on the 14-day thing and somebody did a 5-day course, I was judgmental. And I was like, that doesn't seem right to me. That seems wrong. And now looking back, and I feel bad because I judged that person and I should have known. So anyway, hopefully if people are listening to this, it is okay. You can treat a sporadic UTI with 5 days, 3 to 5 days actually, but go to the 5 days if you're really, you know, worried. Some other things I learned were, you know, not to use TMS and Dobies or any other black and tan breeds. And remember when using TMS, careful of KCS, which we did a podcast on about a month ago. So check that one out. But TMS, it's a great drug, but it's not for every patient. And I also learned that urine should be sterile, correct? We all learned that, right? Urine should be sterile. But turns out urine actually is not sterile. There is a microbiome. It's just that those bacteria don't grow on the plates that we look at. So I don't know which bacteria are in there, but there are some. And for chronic deep-seated infections, there is a drug that you can use called nitrofurantoin. If you give it nightly for 4 months, it can really help with those types of infections. Did you guys ever know about that one?
Yes. I've also used it in down dogs that get recurrent infections, back dogs that are paralyzed on the advice of one of the internists at Penn.
Nice.
Let's move on to Dr. Carney's lecture. And this was actually a controversial lecture about whether or not you should split up vaccines. So how about when you guys vaccinate, Do you ever recommend splitting vaccines, maybe in a small dog or a
All the
puppy?
time.
Yep, me too.
All the time?
Yes.
So it looks like everybody here does. Yeah, I do too. And it was interesting to hear the data presented. So statistically speaking, he argued that the risk of adverse reactions is actually higher when you split them. And the reason is there's a certain percentage from any given injection that will cause, there's a certain percentage risk, right? But the risk doesn't go up additively when you do them all together. It's actually a much smaller risk when you do them all together. But if every 2 weeks you're giving one injection, you're actually getting sometimes 300, 400, 500% increase in the risk of seeing a reaction. So it seems a little counterintuitive, but he's saying that is probably the most important reason to not split them up. He was also talking about how back in the year 1900, one vaccine had 200 antigens, and today 20 vaccines is only 125 different antigens. And it would take 10,000 vaccines before you would overwhelm an immune system. So that number to me was like, whoa, we're all afraid of these vaccines. It's unfounded. We really shouldn't be so afraid. And they've gotten so much cleaner, and the antigen levels are so much lower in these new vaccines that he said putting them together really is actually going to get more compliance. It's better for stress levels for the dog to not have them keep coming back in, or the cat. And the risk is much lower actually of reactions.
Anecdotally, I feel like I do see more reactions when I'm grouping more vaccines together. Now, whether or not that pet would have reacted to that vaccine regardless, I don't know. But I do think it makes it hard sometimes, because then say I'm giving 4 vaccines and they have a reaction. Now I'm not sure which vaccine was the culprit.
Yeah.
So how would you proceed in a case like that where they've had a reaction in the past and now you want to go forward? Would you just pre-medicate and continue to do them all, or would you split them up then at that point?
I think he said pre-medicate and do them all together, or pre-medicate and split them up, once you know, and then maybe you can figure out which one it was. Or if they have a reaction, don't give them any vaccines. If they're older pets, like don't give them the distemper vaccine anymore. Limit the number of vaccines that you do to just the ones that you think they have a high risk for. So, an older pet getting distemper parvo, like when they're 10 years old, probably not necessary. But like a Lyme or lepto still might be necessary.
Statistically speaking, though, I have heard that the most common time for them to react is either the last puppy vaccine or the first adult vaccine. And if that's the case, and you give them 4 vaccines at once, then you really don't know what to do. And they're still in the prime of their life, and they're still running around getting into everything. And that's my main reason for telling owners I don't like to use more than 2 at a time, is because then at least I have a 50-50 chance of knowing what they reacted to.
Yeah, and I had a problem with it too, because when I did my internship, I was on ER a lot, and I would see animals coming in with what we diagnosed as IMHA, and a lot of times they had been given 5 or 6 vaccines. But here's the thing: so almost every animal gets 5 or 6 vaccines now. So it's like it's hard to know if that was the reason. Would they have gotten it from 1? Would they have gotten it from 2? Because so few patients actually get 1 or 2 at a time. So it also, I don't know. I wasn't completely sold, but that was his recommendation. And he teaches at Cornell. He actually teaches in the community practice there, so he does a lot of this stuff. And he did a study. So
I'm excited to have more and more combo vaccines coming out. I like when everything's just all in one.
Oh, love the combos. All right, so the next one, I know that you guys were in with me, right? This was the psychopharmacology lecture by Dr. Megan Herron. All right, so Chaundra, why don't you take us through this one? I've been talking a lot.
So Dr. Herron was talking about the different medications that we can use. It was actually a 2-part lecture. The first hour was on long-term medications, and then the second hour was on more event-based daily meds. So she sort of broke it down into the categories like, SSRIs versus TCAs versus MAOIs, and just some quick little tidbits. Some of the SSRIs, so we talked about fluoxetine and paroxetine, and the side effects on those tend to wane with time, which usually happens over like a 4 to 6 week period. Common side effect with fluoxetine is decreased appetite. So use caution if you have those cats that are known finicky eaters. Maybe fluoxetine is not the best choice for that particular patient. And then you also want to wean fluoxetine off over months and find the lowest effective dose. So it's not something that you can just be like, it wasn't working, let's just stop that. Like you want to, or if you think that the behavior is resolved and you want to try to back them off, you almost need to wean it as long as it took you to get to the effective point. You almost need to wean it as slowly.
Yeah. There was one other side effect that I learned from her with using fluoxetine in cats. You got to look out in the first week for urinary blockage, functional urinary blockage. I don't think I knew that. Mm-hmm. So that was a good tidbit.
Yeah, and that happens with the paroxetine as well. So it's some of the SSRI side effects in general. Like they can get some urine retention, which in rare cases can cause a functional obstruction in cats. So you want to watch and make sure, warn the owners to make sure that they're urinating regularly. Paroxetine was a great drug to use instead of Prozac if you have those finicky eaters, because it can actually increase appetite. And it can even firm up stools if you have dogs that have more chronic loose stools. But obviously, you don't want to use it in patients that have a history of obstipation, because that's going to take you in the wrong direction.
Oh, I was just going to say, I don't know if Dr. Herron talked about it in her lectures, but when I was at ACVC last year, actually, they talked about splitting the dose of the SSRIs instead of giving it once a day into half dose twice a day to reduce the risk of GI effects.
Well, fluoxetine is once a day, and paroxetine, I believe, is twice a day. So paroxetine's already twice a day, and then I guess so you're saying fluoxetine twice a day.
Yeah, so I can't remember who gave the lecture now, but I remember him talking about with the fluoxetine, really just splitting it up so that you have decreased risk of side effects, decreased risk of that decreased appetite or GI upset that can sometimes happen. And over time, you can sometimes switch back onto the once a day dosing. But he said that he felt like most of his clients and patients did really well on twice a day long term.
Good to know.
Yeah.
All right, Chaundra, what did you learn about the tricyclics?
Same thing with the side effects tend to wane over time there. So again, another 4 to 6 weeks. The anticholinergic effects on the TCAs tend to lead to a greater side effects profile, but they also have antihistamine effects, which can lead to greater calming effects, which is nice there. Clomipramine, she was suggesting that it be used to treat those bully cats and those little ants in your pants dogs that can't sit still. And then from the daily lecture, one of the things that she said is you can use trazodone as a bridge medication while you're waiting for the SSRIs and the TCAs to reach their peak effect. You can use trazodone to kind of help get them there. Yeah.
I remember hearing that people were worried about like serotonin syndrome from doing the two together, but I think she said she's never seen that happen. So it's good to know. Mm-hmm. All right, the MAO inhibitors.
Yeah, there is some risk of serotonin syndrome here when you combine it with tramadol or other opioids, and you treat that with ciprofloxacin. So that was a good little thing to know. Side effects, you can get testicular hypoplasia. So for clients who are particularly attached to those organs, that may be something of note.
Who is?
You can get moderate, right? You can get moderate anticholinergic effects with the MAOIs as well. So some dry eye, dry mouth, some urine retention here, constipation. You want to avoid it in pets with history of obstipation or glaucoma or KCS. Amitriptyline, interestingly enough, can lower the seizure threshold. So use caution in patients that have a history of epilepsy, and you can get some severe urine retention with amitriptyline as well. So I thought that was particularly interesting because I know a lot of people will use that for cats with inappropriate urination. And then not from this lecture, but she did mention doxepin, and I had picked up somewhere else that I know people are starting to use this to treat geriatric onset laryngeal paralysis and polyneuropathy. So I thought that was just kind of a cool little side note.
We should save that one for our off-label drug usage. Remember we did that one podcast on that? We should do another one. We should add that to the list.
Yeah. And then lastly, for the MAOs, Boost Bar is the quote bravery drug. And she said you can use that to treat fearful, non-aggressive dogs and cats.
Good to know.
And then I think you had some notes about the benzos.
I learned that lorazepam is really the only benzo that we should be using in cats, because remember, Valium is going to be something that can cause an acute hepatic necrosis in some cats. Actually, Marissa taught me that. Mm-hmm. You know, I try to stay away from the benzos because I was burned once by a client who was abusing them. And so after that, I kind of learned my lesson, and I'm very, very cautious with the pets that I put these things on. So, you know, usually I would try something else before jumping to these.
I've definitely had the paradoxical excitation.
Yeah.
They're not my favorite for behavior modification and training either, because they do create a decrease in short-term memory production. So it can be harder to train or for their pet to learn when on the benzos. But in specific case-by-case situations, like with, you know, storm phobias and things like that, or just coming into the vet, maybe I find them to be helpful as an add-on.
She said they were the best treatment for panic and profound fear, and that the increased appetite side effect can actually be a really helpful thing when it comes to the behavior mod, because they're super interested and then receptive to food treats and stuff.
Yeah, and they can become addictive for pets too. Mm-hmm. So when you do take them off, if they're on them for a long period of time, you really have to wean them down. All right, so Dr. Ilana Reisner, she's local here in Pennsylvania, and actually I've been referring to her my whole career here because I had heard that she was great. I had never met her, so this was my first time seeing her speak, and she went through behavior modification. So that was a good segue actually from some of these drugs. I think she was in the room with us. So what did she talk about? Who was there with us?
I was there.
Kelly, what did you learn? Come on. Did she teach you anything?
Yeah, I learned lots of good stuff. It was more of, especially with the training behavior modification things, a little bit more of a refresher, but some new things as well. You know, so I do encourage all of my clients to work on training with their pets, because it does build increased confidence, both for the owner and for the pet, which can really help with behavior modification when dealing with other anxieties or issues at home. Some of the things that she mentioned in particular, which I really liked, was the target or touching. I do find that really useful and actually use it with my own dog at home when having new people in the house. So I have her go say hi, she goes, sniffs their hand, and then comes back to me and gets a reward. And that helps cut down some of the excitement and the jumping, which I think a lot of us struggle with our pets, is that jumping up on people. Something new that I haven't used before was the chin rest. That
was very cute. Those videos she had were really cute.
It was adorable. And so I love it. I definitely want to teach it to Peanut, but I thought that would be so great. And, you know, it really will help, one, get your pet to focus on you and come to you because they're resting their chin in your hand. But two, they can't be barking and going insane when their face is in your hand. So I think that that's a really great tool for that as well. And then my other favorite one, there's quite a few things, but was the settling on your mat or going to your place. I think that's really good. I use that in my home as well with my dog. I have her go to her place if she's getting too worked up or if people are coming over, or if I, drop a glass in the kitchen. That way she has some place safe that she can go to. And I also use her place as a safe place for her. So if she's feeling overwhelmed, if there's people over, she can go to her place and have a nice, safe, calm area where no one's going to bother her.
I also, she showed us a video of Chirag Patel's bucket game, which I thought was super cool. And I've actually recommended this to a few of my clients already. Do you guys remember what that was?
I can't remember. Can you remind me?
Yes, I can. So basically you have a, quote, bucket or bowl of some sort full of treats that you set in front of the dog, and you have the dog focus on this pile of food. And while they're focused on it, you have someone that is continuing to dole out the treats at a certain interval and keep the dog's focus. Meanwhile, a second person, or maybe your second hand, is doing some type of stimulus to the dog to get them used to that stimulation. So in the video example, they had clippers. So they were, turned the clippers on and held them away from the dog so the dog could get used to the noise, and then gradually brought them closer and then touched the dog with the non-cutting end of the clippers. And as long as the dog was focused on the bowl, they kept continuing with the stimulation. But as soon as the dog got distracted by the stimulation and tore their focus away from the bowl, all the stimulation stopped, the treats stopped, everything stopped until the dog returned focus to the bowl, and then the treats resumed again. And so you can kind of gradually desensitize them and change their perception, make it a positive one, change their association over time.
I'll put that in the show notes for people who are listening so they can look up the YouTube videos. So it's Chirag Patel.
Yeah.
He's a trainer, right?
Yep. Somewhere over in Britain.
Cool. All right. So Chaundra, you also wanted to talk about cat arthritis. You went to a Silencia lecture.
I feel like Silencia was everywhere. There were It came up in every lecture that I went to that was even remotely associated with pain. There were at least a few slides on Silencia. So the one thing that I wanted to throw out, and I guess these can go in the show notes too, Dr. Kristen Shaw gave a talk about pain management in cats, and she had some resources that were sort of along the line of the COAST studies and stuff, the things that we have to help evaluate dogs for arthritis and help owners try to determine what signs they're seeing at home. So they've developed some of these things for cats. So Zoetis has a feline exam videos resource page, and then there's also a cat OA checklist. And then if you go to silenciavetteam.com, they have a lot of resources up there just to help us and help our owners identify which cats may be affected by arthritis.
Cool.
I'm so excited for Silencia. I cannot wait for it to come out. Some clinics have it already, very limited supply to do little trials, but it's supposed to be officially released in October of this year.
I'm super excited. I've been videoing my cats running so I can watch them in slow-mo and be like, are you arthritic? Do you need Silencia?
I know.
Wow, so that's soon. Awesome. All right. So there was another lecture, Chaundra, that you went to that I didn't go to, which was Carrie Journey's CPR for the veterinary soul. That sounds nice.
Yes, it was a good lecture. She broke down veterinary personality types and individual tendencies that are all too common in our profession, as well as some common workplace stressors. I have to say I felt very seen, and I'm not sure that I liked it. I identified with what was on the screen there and was I feel like I'm being called out. This is totally me in every sense of the word, and I'm not sure that I like this feeling. So there were some great resources that she put up there. There were 2 training for suicide prevention options that she gave. One is QPR training, which is the www.qprinstitute.com. And then the American Foundation for Suicide Prevention also has a website, afsp.org, and they have free training up there for people that are wanting to get a little bit more information in how to identify and help prevent and de-escalate some of these situations. And then another resource that she gave that I thought was really fantastic was ways to help veterinarians find the right match for mental health care providers. So betterhealth.com/NOMV, not one more vet. They can help you get matched with a licensed therapist, and you can actually get a free month of professional online counseling through that website. And then her other recommendation was Psychology Today's Therapist Finder. And that website has a ton of filters on there where you can actually pick language, gender. They even have a non-binary option in the gender drop down, insurance type, price, ethnicity, sexuality, faith. So you can have all kinds of different nuances to help find the therapist that's going to be particularly right to you.
Awesome. Yeah, all those links will be in the show notes. All right, cool. Well, Amy, you went to a lecture by Jane Sykes on leptospirosis. So what did you learn there?
Yes, I did. And I've seen several cases of lepto in my career. And what I did not know, what was new for me, was I didn't know turtles could be reservoir hosts, as can amphibians. So I don't know if anyone else knew that, but that was new for me.
Oh. And my kids pick them up all the time when they see a frog jumping around. They try to pick them up. Yeah.
I found that very interesting. And of course, we all think about renal and hepatic disease, but they said they also get myositis, which I was not really aware of that as well. And that can be some of the reasons for abdominal pain. One of my best friend's dogs actually got lepto, actually died of lepto. And the initial presenting complaint when she called me the night before the dog was seen was that the dog was turning around and looking at his butt. And I went, I don't know what that means. Maybe it's his anal glands. And he was only 3 years old. So now I wonder, what did he have back pain? And at the time I thought maybe he had kidney pain when I looked back on it, but perhaps it was myositis. I don't really know. So I found that to be interesting. Also, I did not know that other than icterohemorrhagic, the icterohemorrhagic serovar, I did not know that there is an actual pulmonary hemorrhage syndrome associated with leptospirosis, and that can occur in both humans and animals. She did not say it was related to DIC or sepsis, just specifically to leptospirosis.
Wow.
So I don't know. Did any of you guys know that? Because that was all new for me.
No, that's great. Thank you for adding that in.
Yeah,
That's awesome.
No problem.
All right. Well, what about the common cat cancer lecture you went to by Corey Saba?
So probably one of the most interesting things I learned is that nasal lymphoma isn't necessarily systemic and may respond to radiation alone. I think that I knew this, but I feel like I always still give people a very guarded prognosis with anything involving lymphoma other than small cell GI lymphoma, which I have treated successfully as a GP. That's the only one that I ever give people like a good feeling about and feel very positive. So it did change my thinking about nasal lymphoma. She said that most of these cats respond very quickly with radiation alone, and that the prognosis can be about a year with radiation alone. So I thought that was really cool. Have you guys seen that? Have any of your clients done that?
None of my clients have, no.
So that's something that I think I could get people to do and have their cats have an extra good year. Also, I mean, of course, we know with small cell lymphoma that we can treat it as a GP veterinarian. Prednisolone and chlorambucil is best. She said that they can have about 1.5 years. I will say that I personally have diagnosed cats with full thickness exploratory biopsies and gotten 2 years and a little bit more. So I'm always very positive about that one. That for me is exciting. The other thing I didn't know is injection site sarcomas, which are a really big deal to me and I talk to everyone about, can include extraskeletal osteosarcoma. And I have never seen that. Have you guys seen that?
No.
I hope I never do.
I know. I thought that was really bizarre. I was like, I did not know this. And you probably heard the 1, 2, 3 rule before. Increasing in size after 1 month, larger than 2 centimeters, still present 3 months after vaccine. The other thing that I didn't fully realize, because back in the day we used to do our own surgeries for these, and now of course everyone sends them to someone boarded, as we should. But even a boarded surgeon doing a complete excision, there's a 42% recurrence rate.
I was a lot higher than I would have thought.
Same here. I was a little surprised and disappointed about that, and a 21.7% metastatic rate, which, you know, initially we all thought that they were just locally growing, rapidly invasive masses and not so much metastatic. Of course, we've all seen metastatic disease with them, but I thought that was a higher rate than I was expecting. And so we all need to follow the guidelines.
Always.
Yep, absolutely. All right. Well, that was definitely a good update on cat cancers. Thank you. So when you said extraskeletal osteosarcoma, you mean, so like in the soft tissue, you'll see an osteosarcoma?
Yes, completely unassociated with bone.
Interesting. Okay.
I wonder if that has something to do with maybe when you're giving the vaccine, if you go in really hard, like if it's a feisty cat and you're just trying to get in there and you scrape the bone or something.
I don't know. She didn't say that. It was just very interesting to me because I've never seen that, and it wasn't anything I had ever heard of before.
All right. Well, the last lecture, Amy, that you put on here was Mary Tell's keratoconjunctivitis Zika lecture. And interestingly, we had Casey Robinson on a couple of podcasts ago, and we were talking about KCS, and I named it Casey Yes because Casey was there. I don't know if you heard it, but so maybe let's see if there's something here that he didn't talk about. What did you learn there?
The interesting part for me, just a very brief thing, we all know about immune-mediated KCS. But neurogenic is a little less common, and for me, a little more interesting. I've seen a couple cases in my career. One was associated with hypothyroidism, and that's something that's a relatively common cause. But what I didn't know is that it can be caused by long-term otic preparations like Ocernia and Claro. And so it's just something for all of us to watch out for. I use a lot of Claro, and it made me really think, should I be using as much Claro as I use? I use it because it's easy for the owners. It works great. And maybe that's something that I shouldn't be using as often unless you really have to, or people are really failing at using other things.
Do they mention that it was like repeat uses of it, or is it just like one time can cause it?
I got the feeling it could just be one time. She didn't talk about if it was repeat uses or not, but it's most commonly unilateral. So I was sort of picturing it was less likely to be chronic because one of the other causes is chronic otitis, trauma, neoplasia. So she included all those as causes, but this was specifically use of long-term otic preparations. So I found that to be interesting, and it's not treated the same way since it's not immune mediated. It's treated with pilocarpine ophthalmic solution, but you give it orally. In the past with the 2 dogs I've had, very small number, I've had people put the drops in food, and it has worked. They usually also have an ipsilateral, very, very dry, crusty nostril, which you probably already knew. Of course, since it's a parasympathetic drug, you need to watch for toxicity that includes salivation, vomiting, diarrhea, bradycardia, and weakness.
Awesome. Those are great updates. Thank you.
You're welcome.
I learned from that, and hopefully the audience listening learned from that as well, from all of the things that we talked about. So thank you, everybody, Amy, Kelly, and Chaundra, for being here today with me in Marissa's stead. You guys are doing a great job as clinical leaders of this company. Awesome. Keep it up. And hopefully the next episode, Marissa will be back, and hopefully she liked listening to this one instead of being on it. So I hope you all enjoyed this episode of the IndeVets Happy Hour. Thank you for listening. Tell your friends, your vets, techs, general public, and if you like us, leave us a 5-star review. And make sure to subscribe so you can be alerted whenever we have a new episode, which currently is on the 1st and 15th of every month. If you have questions, comments, suggestions for future episodes, please email us at clinical@indevets.com. Thank you so much. Cheers.
Cheers.
Bye.
Cheers.
I'm a veterinarian, sure, but I'm way more than that. I'm also a tango dancer, a struggling but determined pie maker, and a mom. With IndeVets, I get to choose when and where I work. I create my own schedule and choose shifts at nearby animal hospitals that are right for me. Having that flexibility is exactly what I need to have plenty of time for all those other things that I am. Because I'm more than just a vet. Visit IndeVets.com to learn more and apply.